Hi everyone, this is Joel Estacio and I'm going to present to you my study which is entitled Health Education Among Patients with Type 2 Diabetes Mellitus, a meta-analysis. The World Health Organization in 2012 has recorded 2.2 million deaths as a result of increased risks of cardiovascular and other diseases. Also, they have recorded 3.7 million deaths, and these are all due to higher than optimal blood glucose levels. Diabetes mellitus remains to be a global public health burden. The World Health Organization, in their Global Report on Diabetes in 2016, stated that the disease is no longer a problem primarily among high-income countries, but alarming incidence has also been increasing in middle-income countries. Furthermore, an increase from 108 million to 422 million are diagnosed with diabetes from 1980 to 2014, respectively. Moreover, estimates are expected to explode to about 439 million adults by 2030. Majority of this, that's 69%, is projected to occur in the developing countries. In the United States, the Centers for Disease Prevention and Control estimates that a total of 29.1 million people are diagnosed with diabetes in 2012. Also, in India, which is actually one of the largest in terms of incidence among all countries, they have predicted to have about 79.4 million in 2030. And next to India, we have China, which is predicted to record 42.3 million individuals carrying the disease in 2030. Arab countries also recorded towering numbers of this deadly disease, and they have recorded that among those with type 2 diabetes mellitus, there has been rise in incidence from 2.5% to 23.7% from 1982 to 2004. Now, it was posited that the increase in the prevalence of diabetes will result to increased burden, especially among those belonging to the low-income societies. This yield serious socio-economic burden, particularly in terms of healthcare expenses, causing increased healthcare costs among those affected with the disease. In 2010, it was estimated that the total global expenditure for diabetes was about 376 billion US dollars, and it is predicted to go up to about 490 billion in 2010. That's a record from Zhang et al. In 2010. And also, globally, recent estimates has been as high as 245 billion of direct and indirect medical costs in 2012. That's according to the Center for Disease Prevention and Control in 2014. Now, these trends call for serious healthcare programs that aim to focus on prevention, health promotion, and effective management systems. Lifestyle modifications are considered to be the cornerstone of diabetes mellitus, with emphasis on diet, exercise, monitoring, and self-management. Health education provides an indispensable part of these health programs addressing diabetes, which is why in this review it is aimed to determine now the effect of health education programs to glycemic control among type 2 diabetic patients This provides more up-to-date evidence on the use of health education programs to address the increasing demand of managing diabetes across various populations, thus providing support to help augment existing health programs in terms of co-management of diabetes with the affected patients. This review involves the selection of studies which are randomized control trials, participants with type 2 diabetes mellitus, which are adults greater than 18 years old. Patient education programs should be the cornerstone of their interventions. The outcome measures should be the HbA1c measured in percentage, which is measured at least 6 months follow-up. Only those which are published January 2001 to May 2017 were included in this review, and those studies which failed to report complete measurement values were excluded. We can see now here the search, screening, and selection of studies. So at first, systematic literature search was conducted in electronic databases of EBSCO hosts, which include Medline, CNAL, and health resources. Using the terms education, diabetes mellitus, and randomized controlled trials. The search was conducted in May to June 2017, and only those which are published in English language are included. And studies identified through the search was 980. And after removal of duplicates, we now have a total of 835 studies which were subjected to screening based on their title and abstract. 743 were excluded, yielding now a total of 92 studies for retrieval of their full text articles for review of their eligibility. Now, out of 92 studies, I have excluded 74 which did not satisfy those eligibility criteria. We now have a total of 18 studies which were included in the quantitative analysis. For the data extraction, I used data extraction forms which I have created, and this focused on the determination of the characteristics of the participants, the characteristics of the intervention, the methods, and the outcome measures. For the quality assessment, since I have included only those which are randomized control trials, I used the Cochrane risk of bias tool to determine the quality of the studies included. For the analysis of data, I used the trial version of the Comprehensive Meta-Analysis version 3. Here is an example of the data extraction form filled up. Here is another example of the data extraction form for the outcome measures. Here is a sample of the Cochrane risk of bias tool. Okay, for the results, a total of 18 randomized control trials turned out to be a part of this meta-analysis. And these 18 randomized control trials were all subjected for the assessment of quality, and it is shown that most of the studies included appear to have unclear risk of bias. That's 16 out of 18. Most have insufficient reporting in terms of blinding and allocation concealment. This is because of the nature of the intervention. However, even though these studies did not turn out to have low risk of biases, previous studies which conducted a meta-analysis that is similar to this study have mentioned that randomization is the only assessment criterion in terms of determining the quality of these studies. Most of the studies included in this meta-analytic study have provided clear methods of randomization. That's 16 out of 18. Okay, for the study characteristics, a total of 4,754 patients were included in all of these RCTs, which were conducted in various countries in Asia, North and South America also. We also have countries in Europe and in Africa. The number of participants in each study ranged from 62 to as much as 1,570. Most of the studies reported mean age of the participants in late 50s, with the youngest reported mean of 49.1 and the oldest is 66.1. The interventions were extracted based on the mode of teaching, the setup, the content of educational intervention, and the profession of the providers in charge of delivering the health education. Most of the interventions provided were conducted face-to-face, so most still have utilized the traditional personal counseling as a method of providing health educations. However, you can see here in the table that some emerging techniques have been used, like the utilization of web-based or internet-based interventions, multimedia, and through telecommunications. This type, the type of setup of interventions, also, you can see that they are almost equally distributed as to whether they have used group or individual setups. There are also studies which used combinations of these setups. For the content, they mostly include diet, exercise, and basic information about diabetes, with the highest number of interventions that include self-management content in their health education. So here are the other studies which were included in the assessment of their characteristics in terms of the participants and the intervention. Also under the results, assessment of the publication bias through the use of funnel plot was conducted. So you can see now here in the funnel plot that the distribution of the studies, when graphed with the standard difference in means along the x-axis and the standard error along the y-axis, that many of the studies are fairly distributed along the upper portion of the funnel, which represents the studies which provided high sample sizes. At the base of the plot, 3 out of the 4 studies are distributed and geared more towards the right side of the mean effect size. This presents that the studies are fairly distributed within the funnel, and so the likelihood of having publication bias is low. This result may be taken into consideration by the readers when looking at the results and implications of this study. Now, to further analyze this plot, I have here the result of the Eggers test, and as you can see, results show that the intercept gave a p-value of 0.504. That's confidence interval 95% of is negative 2.787 to 1.413. Now, this result indicates no evidence of publication bias among the included studies. Here is now the result of the forest plot, and to achieve this result I have conducted meta-analysis using the random effects model. This figure now shows that the meta-analysis result of the effect of health education among participants at 12 or 6 to 12 months after the intervention. It shows that at 6 to 12 months, intervention and control groups have a standard mean difference of 0.33. That's a confidence interval of negative 0.485 to negative 0.181. This indicates that the intervention group achieved an HbA1c level that is 0.33% lower than the control group. The confidence interval suggests that the mean HbA1c among those who undergo health education programs can be 0.485, or that's 0.181 to 0.485 lower than those in the control groups undergoing the usual care, suggesting that the difference would always favor the intervention group. Now, the forest plot also shows that the mean difference of all the included studies are fairly distributed and almost similar, except for some studies which yielded extreme differences between the two groups. The observed effects are fairly consistent. Most of the study's effect sizes favor the intervention group. The summary effect has a z-value of negative 4.299. That's a p-value of 0.000, which indicates that the null hypothesis that the mean difference of HbA1c level among the two groups is 0 is rejected. You can now see here the heterogeneity result of the study. The study's heterogeneity was tested and results were shown in this figure to test the null hypothesis that the observed variances in the studies are due to sampling error. Now the Q values you can see is 133.844 compared to the degree of freedom, that's 23, yielding now a p-value of 0.000, indicating the evidence of variations from study to study are not only due to sampling error. Furthermore, you can see in the I-square that it yielded 82.816. This indicates that the variances are reflected in the forest plot are due to an increased or an estimated 83% variances in the true effect sizes. These are not due to the sampling error. The variance in the effect size is estimated to be about 0.103, as you can see in the tau square value. Or it could be an estimated 0.322, the tau value at the right end, which reflects the standard deviation in the true effect sizes. We can see here that based on the results, that interventions that were provided to patients varied from one study to another. However, most relevant findings was that there had been integration of technological advancements in the provision of health education for the patients, and indeed, the emergence of innovations in the health education presented in the studies, like the use of internet, mobile applications, and telecommunications, provided new ways to maximize effectiveness of the strategies provided for the patients, especially because we are now living in the modern world. Okay, for the conclusion, it supports now incorporating effective patient strategies that comply with the need and adapt with the culture of individuals to whom education will be provided for. This also suggests that healthcare providers must continue supporting the existing programs or developing health education programs that address the needs of the patients. Also, patient education, indeed, is a great factor that contributes to the success in managing chronic health conditions such as diabetes. And further investigations that focus on the sustainability and long-term effect of these patient education programs is still a necessity. Here are the references. Thank you very much for watching.